Something is happening inside your nervous system right now that you cannot feel. A slow, progressive deterioration of the insulation wrapped around your nerve fibers, the biological equivalent of the rubber coating on an electrical cable starting to fray. When that insulation is intact, signals travel fast, clean, and precise. When it starts to break down, signals slow, scramble, and eventually stop reaching their destination. And the reason this matters is that the damage can be well underway before a single symptom appears. By the time most people notice something is wrong, the neurological process has often been running for months, sometimes years. Vitamin B12 deficiency is one of the most underdiagnosed conditions in the developed world, and it has a particular cruelty to it. It builds quietly. It mimics other conditions so convincingly that it gets blamed on aging, anxiety, poor sleep, or stress. And it causes damage that in many cases cannot be fully reversed once it is caught late. What I am going to walk you through today are the 8 signs that your nervous system is telling you something is wrong, signs that most people either ignore, explain away, or never connect to a single nutritional deficiency. The important word here is silent, not because these signs are invisible, but because they are so easy to misread. A tingling in your feet that you put down to sitting awkwardly. A memory lapse you chalk up to getting older. A persistent fatigue that your GP runs routine bloods for and calls unremarkable. These are not random complaints. In many cases, they are your nervous system sending you a specific biological distress signal. And the earlier you recognize them, the better your chance of reversing the damage before it becomes permanent. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years in the AANDE, I have seen what happens when slowly progressing deficiencies are missed. Not once, not occasionally, but routinely. People come in with weakness on one side that turns out to be nothing to do with stroke, but everything to do with unchecked B12 deficiency causing spinal cord degeneration. People in their 50s experiencing what looks like early dementia, where the real driver is a correctable nutritional problem that has been running undetected for years. And my goal now is to help people catch these things earlier, understand what their body is telling them, and avoid the outcomes I see too often on the front line. For the next couple of minutes, before we get into the 8 signs, I need to walk you through what B12 actually does inside your nervous system, because without that foundation, the signs make no sense. And understanding the mechanism is what turns a vague list of symptoms into a clear picture of what your body is actually experiencing. I promise to keep creating the most helpful videos I possibly can, grounded in science and the latest research designed to help you live longer and prevent the diseases I encounter every single day in emergency medicine. And all I ask in return is that you give this fairly new channel a chance and hit the subscribe button. If you get to the end of this video and you did not think it was worth your time, or you have not learned something genuinely new, then feel free to unsubscribe. No hard feelings whatsoever. But if you give me your time and your attention, I will give you everything I have learned from over a decade in medicine. Please hit that subscribe button to help this channel reach more people like you, and let us continue. To understand what B12 deficiency does to your nervous system, you need to understand one structure above everything else: myelin. Myelin is a fatty substance that wraps around the axons of your nerve cells, the long filaments that carry electrical signals from your brain and spinal cord to every muscle, organ, and sensory receptor in your body. Think of myelin the way you think of the insulation on a copper wire. The wire carries current perfectly well on its own, but without insulation, it bleeds charge, picks up interference, and eventually shorts out entirely. Myelin does the same job biologically. It keeps nerve signals sharp, fast, and properly directed. Without healthy myelin, signals slow down, scatter, or fail to arrive at all. Here is why B12 is so critical to that structure. Vitamin B12 is an essential cofactor in a biochemical process called methylation. One of the key methylation reactions in your nervous system produces a compound called S-adenosylmethionine, which your body uses to synthesize and maintain myelin. When B12 is insufficient, this reaction stalls, myelin production drops, and because myelin is not a static structure, it requires constant maintenance and renewal. Existing myelin begins to degrade faster than it is being replaced. The result is a process called demyelination, and it progresses quietly for a long time before it becomes clinically obvious. Now, there is a second pathway where B12 deficiency causes neurological harm, and this one operates through a compound called methylmalonic acid. When B12 is low, methylmalonic acid accumulates in the nervous system and is directly toxic to neurons. It disrupts mitochondrial function, the energy supply inside nerve cells, and interferes with the synthesis of the fatty acids that make up myelin itself. So you have a double mechanism, myelin failing to be built properly on one side, and existing nerve cells being chemically damaged on the other. Research published in the journal Neurology has shown measurable changes in nerve conduction speed in people with B12 levels that would still be considered within the low normal reference range by standard clinical criteria. The third component to understand is that B12 deficiency affects which nerves are damaged first, and this is not random. The longest nerve fibers in the body are the most vulnerable because they require the most myelin maintenance over the greatest distance. This is why symptoms begin in the hands and feet rather than the core. The peripheral nerves serving your extremities are the first to show functional changes because they have the furthest to travel and the least tolerance for myelin disruption. Over time, as the deficiency deepens, damage moves progressively inward, affecting the spinal cord, the optic nerves, and eventually the brain itself. And the fourth layer, the one that makes B12 deficiency particularly deceptive, is absorption. B12 is not simply absorbed through the gut like most nutrients. It requires a carrier protein produced by specialized cells in the stomach lining called intrinsic factor. Without intrinsic factor, dietary B12 cannot cross from your intestine into your bloodstream, regardless of how much you eat. As we age, intrinsic factor production declines. Certain medications, including proton pump inhibitors and metformin, interfere with it directly. And conditions like gastric atrophy, celiac disease, and inflammatory bowel disease can destroy the cells that produce it entirely. This is why B12 deficiency is not simply a vegetarian problem or a dietary problem. It is, in many cases, an absorption problem that has nothing to do with what a person eats. That is the biological foundation. Now let us talk about what this looks like in a real person, because the signs are specific and they are recognizable once you know what to look for. Just really quickly, if you are getting genuine value from this video so far, please consider subscribing. It takes 1 second and it genuinely helps this channel reach more people who need this information. Here is the mistake that most people make, and I have seen it play out countless times. They notice 1 or 2 of these signs, they mention it to their doctor, and they are told it is probably nothing, or they are given a blood test that comes back at the low end of normal, and they are reassured. What they are not told is that the reference range for B12 on a standard blood panel is based on population averages, not on the level required to protect neurological tissue. A result of 180 picograms per milliliter might be technically normal. But research published in the American Journal of Clinical Nutrition has suggested that neurological symptoms can appear in some individuals at levels as high as 400 picograms per milliliter. You can be deficient at the cellular level while appearing normal on paper. Now let us go through the 8 signs, and I want you to pay attention not just to whether you have experienced any of these, but to whether you have experienced several of them together, because the pattern matters as much as any individual symptom. The first sign is peripheral tingling or numbness, particularly in the hands, feet, or both simultaneously. This is the most common early neurological indicator of B12 deficiency. And it is also the most commonly dismissed. People describe it as a pins and needles sensation that comes and goes, often worse at night or after prolonged sitting. What is actually happening is that the myelin around peripheral sensory nerves is beginning to degrade, causing misfired and disrupted signals from the nerve endings in your skin and muscles. I have had patients come through the emergency department reporting persistent bilateral foot numbness that had been written off as poor circulation for 18 months. When we tested their B12, their levels were critically low. That is not poor circulation. That is a nervous system in distress. The second sign is balance problems and difficulty walking in the dark. This one surprises people, but it makes complete sense once you understand the neurology. Your sense of balance in space, what clinicians call proprioception, is carried by a specific set of nerve fibers in your spinal cord called the dorsal columns. These fibers tell your brain where your limbs are in space without you having to look at them. When B12 deficiency causes demyelination in the dorsal columns, proprioception degrades. In daylight, with good vision, most people compensate without realizing it. In the dark, or with eyes closed, that visual compensation disappears and the balance problem becomes apparent. If you notice yourself reaching for walls or handrails in low light, or feeling unsteady in the shower with your eyes closed, that is a specific neurological sign, not simply aging. The third sign is a smooth red or painful tongue, what clinicians call glossitis. This sounds unrelated to nerve damage, but it reflects the same underlying mechanism. B12 is essential for the rapid cell turnover that maintains the mucous membranes throughout your body. The tongue is lined with tiny raised structures called papillae, and when B12 falls, those papillae atrophy. The tongue becomes smooth, often red, sometimes painful or burning. It is a visible marker of the same deficiency that is happening invisibly inside your nervous system. I want to be clear, not everyone with a smooth tongue has B12 deficiency, and not everyone with B12 deficiency will have a visible tongue change. But in the presence of other signs, this is a meaningful piece of the picture. The fourth sign is unexplained fatigue that sleep does not resolve. For most people, feeling tired makes sense. They have not slept well, they are working hard, they are under stress. But B12-related fatigue has a particular character. It is persistent, unrefreshing, and disproportionate to what a person is actually doing. The mechanism involves B12's role in the production of red blood cells. When B12 is insufficient, red blood cells become large and dysfunctional. A condition called megaloblastic anemia, and they cannot carry oxygen efficiently. Simultaneously, mitochondrial dysfunction in nerve and muscle cells reduces energy production at the cellular level. The result is a fatigue that exists at both the oxygen transport level and the metabolic level at once. The fifth sign is cognitive changes, specifically word-finding difficulty, slowed thinking, and mild memory impairment. I want to be careful here because cognitive change has many causes and B12 deficiency is one of several. But what is important is that B12-related cognitive change has a pattern. It tends to involve processing speed and working memory first, rather than long-term recall. People describe it as mental fog, knowing what they want to say, but taking longer to find the word, starting sentences and losing the thread, reading the same paragraph twice. Research published in the journal Neurobiology of Aging has identified B12 deficiency as a potentially reversible contributor to cognitive decline, particularly in people over 60. The reason it matters so much in that age group is that it is frequently mistaken for early-stage dementia, which carries a very different prognosis and treatment pathway. The sixth sign is mood changes, specifically depression, irritability, or what people describe as emotional blunting. B12 is an essential cofactor in the synthesis of neurotransmitters, including serotonin and dopamine, the chemicals that regulate mood, motivation, and emotional responsiveness. When B12 is insufficient, the methylation reactions required for neurotransmitter production slow down. What emerges is a low-grade mood disruption that often does not look like classic depression. It looks more like flatness, reduced pleasure, shortened fuse, or a persistent absence of enthusiasm. I have had patients successfully treated for depression for years who improved dramatically within weeks of correcting a B12 deficiency that had never been investigated. That does not mean depression is always B12, but it means B12 deficiency is under-investigated in people presenting with mood disorders. The seventh sign is vision changes, specifically blurring, double vision, or sensitivity to light, without any obvious eye pathology on examination. B12 deficiency can cause what is called optic neuropathy, demyelination of the optic nerves themselves. This is less common than peripheral nerve involvement, but it is reported in the literature and is under-recognized in clinical practice. When patients report visual symptoms and their eye examination is unremarkable, B12 should be part of the differential, particularly if other neurological signs are present. The eighth sign is muscle weakness, particularly in the legs. As demyelination progresses from peripheral nerves into the spinal cord, the motor pathways, the nerve fibers carrying movement signals from brain to muscle, begin to be affected. This produces a weakness that is different from simple deconditioning. It often affects both legs symmetrically. It may be accompanied by increased muscle tone or exaggerated reflexes, which are signs of upper motor neuron involvement, meaning the spinal cord, not just the peripheral nerves. In its most advanced form, B12-related spinal cord involvement is called subacute combined degeneration of the spinal cord, and it represents one of the most serious and least reversible consequences of prolonged deficiency. These 8 signs are not a checklist to diagnose yourself with. They are a framework for recognizing a pattern that warrants investigation promptly, thoroughly, and before the window for full recovery closes. I want to be very clear before I go through the practical steps here. I am not advocating for any extreme approach, and I am certainly not suggesting anyone modify their medication or treatment without talking to their doctor first. Medication and lifestyle are not mutually exclusive. In the case of B12 deficiency, correcting the deficiency and treating any underlying condition that caused it are complementary. They work better together than either does alone. The first and most important step is getting the right test and understanding what you are looking at when you get the result. A standard serum B12 test is a reasonable starting point, but it has real limitations. As I mentioned earlier, a result in the low normal range does not rule out functional deficiency. If your result comes back between 150 and 400 picograms per milliliter and you have neurological symptoms, I would encourage you to ask for 2 additional markers, serum methylmalonic acid and serum homocysteine. These are metabolic markers that rise specifically when B12 is functionally insufficient at the cellular level, even when the serum level looks acceptable. Research published in the New England Journal of Medicine established these as more sensitive indicators of true functional B12 status than serum B12 alone. The combination of all 3 results gives a much clearer picture of what is actually happening inside your nervous system. The second step is identifying why you are deficient, and this matters enormously because the cause determines the treatment. If you have low dietary intake, which applies to strict vegans and in some cases vegetarians, oral supplementation at appropriate doses may be sufficient. B12 tablets at doses of 1,000 micrograms per day can actually be absorbed in meaningful amounts, even without adequate intrinsic factor, through a process called passive absorption, where a small percentage crosses the intestinal lining without the carrier protein. But if your deficiency is driven by poor absorption, by gastric atrophy, by pernicious anemia, by long-term use of proton pump inhibitors or metformin, then oral supplementation alone will often be insufficient. In those cases, intramuscular B12 injections bypass the gut entirely and deliver the vitamin directly into your bloodstream. Your doctor will guide you on which approach is appropriate for your specific situation. The third step is understanding the timeline of recovery, because this is where expectations need to be realistic. Neurological recovery from B12 deficiency is not linear, and it is not guaranteed. The general principle, supported by the clinical literature, is this: deficiency that has been present for weeks to months tends to be largely reversible with correction. Deficiency that has been running for years may produce improvement that is partial and slow. The peripheral nerves, the ones that cause tingling and numbness, tend to recover better than the spinal cord because peripheral nerves have a greater capacity for remyelination. The cognitive symptoms in many cases show meaningful improvement within 3 to 6 months of correction, provided the underlying cause has been addressed. I have had patients come back for follow-up 3 months after starting B12 injections and describe feeling as though a fog has genuinely lifted, clearer thinking, better energy, improved mood. Not everyone has that experience, but it is not uncommon. The fourth step involves dietary considerations, not as a replacement for supplementation, but as a supporting layer. The richest dietary sources of B12 are animal products: liver, clams, beef, salmon, trout, eggs, and dairy. Nutritional yeast is one of the few plant-based sources that contains meaningful amounts, provided it has been fortified. For people who are already absorbing B12 well and want to maintain adequate levels, ensuring these foods are present in the diet is reasonable. For people with absorption problems, diet alone will not correct the deficiency regardless of how nutrient-dense their meals are. The mechanism is broken, not the diet. And distinguishing those 2 scenarios is exactly why the investigation I described in step 1 matters so much. The 5th step is monitoring, not a one-time test and a box ticked, but a structured follow-up, If neurological symptoms are present, I would recommend retesting B12, methylmalonic acid, and homocysteine 3 to 6 months after starting supplementation or injection therapy to confirm that levels are correcting and that the metabolic markers are normalizing. Neurological reassessment. A simple clinical examination of reflexes, sensation, balance, and coordination should accompany the blood results. Progress may be gradual and subtle, and having objective measures matters both for adjusting treatment and for the patient's own understanding of what is changing. In emergency medicine, you do not see B12 deficiency in its quiet early stages. You see it when it has become something else, when a person comes in with one side of their body not working properly and you spend an hour ruling out stroke before someone checks a B12 level. You see it when a family brings in a parent who has been deteriorating mentally for 18 months and they have been told it is normal aging. And what becomes clear working on that front line is that this deficiency does not just affect a number on a blood test. It changes lives, functional independence, and in severe cases, it changes them permanently. What I have seen repeatedly is that the patients who recover most fully are the ones who had the pattern recognized early, who connected the tingling feet and the mental fog, and the fatigue brought that constellation to someone who looked at it properly, not the ones who waited until the balance problems were so severe they were falling, not the ones who accepted cognitive decline as inevitable, the ones who asked the right questions early enough that the nervous system still had the capacity to repair itself. There is a research study published in the Journal of Neurology, Neurosurgery and Psychiatry that followed patients with confirmed B12 deficiency and neurological symptoms over 2 years. Those who received adequate treatment within 6 months of symptom onset had substantially better neurological outcomes than those who were treated after that window. The difference between early and late treatment in terms of functional recovery was not marginal. It was, in many cases, the difference between full resolution and permanent residual deficit. And this is where I want to end, because I think there is a broader principle worth understanding. The nervous system is not infinitely resilient. It has a repair capacity, but that capacity is finite and time dependent. What B12 deficiency illustrates more clearly than almost any other condition is that the gap between what you feel and what is happening biologically can be enormous. You can feel reasonably functional while significant structural damage is accumulating. And the window in which that damage is fully correctable is real, but it does not stay open indefinitely. The 8 signs I have walked you through today are not abstract medical curiosities. They are your nervous system trying to communicate something urgent in the only language it has: sensation, balance, energy, cognition, mood. Every one of those signs is information. What you do with that information matters. Not your fault if this has been missed. The reference ranges are imperfect. The symptoms are non-specific. The diagnostic thresholds are contested. The system has not made this easy to catch. But you now understand what to look for, what to ask for, and what the stakes are if you wait too long. That knowledge is the difference between catching this early and spending years managing something that could have been corrected. If you found this useful, please subscribe to the channel to help me reach more people like you.